Good afternoon. I am Dr. Anusha Rao, working at Fortis Hospital, Cunningham Road. We had a 44-year-old male, active smoker, with a strongly positive treadmill test in the form of significant STT changes and significant angina. So we went ahead, did his angiogram, which showed a borderline left main stenosis and a long segment LED stenosis with significant LCX disease. It was a right dominant system, so the right coronary artery also showed a significant stenosis. With this in background, we offered the patient a CABG as the first option, but the family was quite hesitant about going ahead with CABG and they wanted a multi-vessel PCI instead. And syntax score being 19, we planned for an OCT FFR guided PCI for this patient. FFR was positive in LAD, so we subsequently planned for a OCT guided PCI for him. The OCT pullback showed a significant long segment plaquing with plaque morphology of lipidic versus fibrotic, and some areas of superficial thick calcium also was seen, and some balloon-induced dissection were also noted since we had pre-dilated the LAD before we did the OCT run. Further, we went ahead and did the LAD stenting. Post-stenting results were good. There were no dissections, there were no malapposition, and stent expansions were good. Further imaging of the LAD to left main showed significant borderline left main stenosis, which had a minimal luminal area of about 5.8 millimeters squared. At this point in time, we were a little confused, so we proceeded and did the FFR post the PCI stenting. Post the LAD stenting, we did the FFR run. FFR was negative to left main, so we decided to leave the left main and did not really stent the left main. Looking back at the literature, this was reported in Circulation in 2004. There was correlation between the FFR and IVUS. It considered a cutoff of 5.9 millimeters squared of minimal luminal area for revascularization. It had a sensitivity of about 93% and specificity of about 94%. So we were probably justified in leaving the left main without stenting. Further, LCX also was positive for FFR. We did an OCT pullback which showed fibrocalcific disease, some lipidic regions, and some balloon-induced dissections also were noted. We went ahead, did the stenting to LCX as per standard protocol. Post-stenting results were also good. There were no dissections that was noted, malapposition, anything that was seen. However, to our surprise, RCA-FFR came negative. But at this point in time, we considered for a conservative strategy, a deferred stenting strategy, but after a lot of debate, we actually thought of doing an OCT run for the RCA as well. So the OCT run showed a focal stenotic area, which was predominantly a lipidic plaque burdened area, which had a minimal luminal area of about 1.14 and area of stenosis of 74%. So again, a lot of confusion as to whether we should consider imaging more superior or physiology more superior. We were in a lot of dilemma. Looking at the old data, there are a lot of positive trials, negative trials for the FFR, but this was a Forza trial which was published in 2020, JACC articles, included 350 patients where they compared FFR versus OCT for intermediate lesions. So in the OCT guided stratification of intermediate coronary stenosis, they included 3 categories of patients. Those were the area of stenosis which are more than 75%, area of stenosis with intermediate stenosis 50 to 75%, with presence of a plaque rupture or presence of a minimal luminal area of less than 2.5 millimeters squared. We are not trying to justify our strategy for PCI to RCA, but at that point in time, considering his age, his symptoms, and the strongly positive treadmill test, we decided to stent the RCA. Post RCA stenting results were good. So there can be a mismatch between FFR and angiographic lesion severity. Some of the independent predictors of false negative FFR are multivessel disease, aging, smoking, diabetes, and a small reference vessel diameter. FFR should be the gold standard choice for intermediate left main lesions. Downstream lesions should also be taken into consideration, and that's how we did the FFR post LAD stenting. Imaging helps in if subsequent BCI is planned. Thank you.